Hello, today we are going to be talking about preparation of the armamentarium and basic injection technique. So as you can see, I've set most things up on the tray already. These supplies can be found in the top drawer, your sterile gauze, your protector that you'll see here. It's one of the things that we use here in our clinic, and then your cotton tip applicators. It's good to have an extra applicator. You're going to have some in order to get your topical out and onto the 2x2 like we talked about, and keeping the container sterile. And so that's one of the things you'll do when you're assembling armamentarium, is just take the jar of topical out of the cupboard or drawer and taking the appropriate amount out of it with the sterile cotton tip applicator and the sterile 2x2. This would be very excessive for 1 or 2 injections, but for your practicals, that might be an appropriate amount. And then you would have an extra cotton tip applicator assembled so that you can use it for drying tissue, or you can use it for angulation for practicing before your first couple of injections. And when we do palatal injections, this will be used for pressure anesthesia. And so with your PPE on, of course you have clean hands and gloves. You are going to assemble the syringe, and so you will take it out of the sterile packaging. Very easily. And then, as you can see, we have our breech loading metallic autoclavable aspirating syringe. We see our harpoon here, and when we look at the cartridge, we can see the rubber stopper on this end, and that is where the harpoon needs to be engaged. And on this end, we see that is where the needle will penetrate as we assemble. And so to get it inserted into the syringe, we'll need to pull back, and you'll see that moves that piston back. And you pull back, and as that goes inside, that makes room for the cartridge. And so now we want our harpoon to become engaged, and so we can't just leave it like that or we're not engaged. So we need that harpoon to be into the stopper. And so we're pressing with our thumb pretty hard. And your harpoons are sharp, and so it shouldn't take much more than this. If you need to twist it just a bit, you can. But now, as I pull back, you can see the whole syringe pulls back, and that's not coming apart from that. So we are engaged, and you want to make sure that harpoon is engaged before attaching the needle. So now we've got our needle, and you can see the bevel orientation is that dot on our AccuJect needles. And so I have selected a 25 short, and so we're going to take the needle penetrating end off, and it just unscrews easily. And now we will very carefully place that into the syringe. And so you're going to press and then start to twist. So righty-tighty, we are going to continue to twist. And now what we need to be aware of as this tightens is our window orientation. So you can see that we have a very short window on this side of the cartridge, and then a longer window on this side of the syringe. We always want to be able to see our big window. And so that way, if we have a positive aspiration and we have a little tiny bit of blood that comes into that syringe, we're going to be able to see that easily, where we wouldn't be able to on this shorter window side. Okay, so now we can see that our bevel is aligned with our big window. Now this would work for a palatal injection. When we talk about having the bevel towards the bone, the window would be up and the bevel would be up for a palatal injection. However, in most of the other injections that we do, we want the bevel opposite the window. And so this is a minor detail, but this is to ensure that should the needle come in contact with bone, and remember, we only purposely do that for the IA injection at a right angle, but for the other injections, we don't purposely contact bone. If the bevel would inadvertently contact bone, the idea would be that the bevel towards the bone would allow it to deflect off of that tissue rather than kind of tear that periosteum and make it a little bit less comfortable for our patients. And so bevel orientation is something that we teach and we talk about. If you cannot get your bevel opposite the window without this being really, really loose, we don't want this really wobbly, but I can see I can give this a little bit of a turn and it's still on pretty tight. And now our bevel is down towards the bone and our window is up. So that is ideal in most situations. Okay, so now we are going to add the protector. And so they've got some perforations and you should be able to pop that through pretty easily and just engage it as far as you can. A little trick I like to use is if you've got the whole tray to work with, which obviously in a clinical situation you won't when you have your instruments here, but for your practicals and when you're just learning, I like to use the corner of the tray and use the lip so that you have less of a chance of this sliding off anywhere, falling off the edge, or your card and your needle cap falling off and becoming contaminated. So how I have this set up is I've got this the long way. It gives it a little bit more stability than this way. It's still pretty stable, but setting it up the long way. And then I have my window down and my bevel up. And the purpose of this card is so that your fingers do not come into contact with the needle. So as you are removing the cap, you want to keep your fingers on the opposite side of the cardboard. But in order to do that, this is engaged pretty tightly. You probably need to, I would suggest using your thumb and your first finger really close to that hub where it's safe and loosening that. And now taking your fingers on the opposite side, I can safely take that cap off. And now I was palm down and now I'm palm up and I'm ready for my injection. Okay, so that is how we want you to take the cap off. And now we are going to be talking about basic injection technique. So I'm going to recap, and we're using the scoop technique. So after it's inside, now I can safely secure that. Okay, so now you can pan towards me. Now we are assuming we have already taken the medical history, we've assessed which injections we need to take, we've taken vitals, we've decided that we're going to do, Cammie needs an MSA on her right side, and I've selected the appropriate needle, which would be a 25 short, and I've selected the appropriate local anesthetic. She doesn't have any allergies or any contraindications to treatment today, and so I'm going to use my Septicane. And so now we are going to position our patient as we would for instrumentation, so kind of the same positioning. And so I'm going to lay her back and just lower her a little bit and make sure I have my light ready to go. And my patient should always have safety glasses on as well, but they have been confiscated, and so I will be very careful, Cammie, I promise. And remember, you are not wearing your loops at this point. We need that larger field of vision, and so we are going to be wearing just safety glasses, or just if you have to wear your loops, you're just not looking through that lens, because we want it a bigger scope to be able to see. So now what I'm going to do is dry the tissue. And so we've got these extra 2x2s and we can use that to dry. So I'm going to find my landmark, and I know that for an MSA, I'm going to be looking at the height of the mucobuccal fold above the second premolar. Okay, and so we're out away from the bone just a touch, and we don't want to go right into the frenum, and we'll get into more details about that later. But I'm just going to dry this tissue just a touch with either a clean cotton tip applicator or a 2x2. And then I'm going to go ahead and apply my topical. So just, this would be an appropriate amount. You don't need more than that. And I'm just going to very gently paint that or apply that. And so a couple different ways you can do this. If you're doing one injection at a time, you can leave that cotton tip applicator in there. However, if you're doing several injections, and most of the time we're doing ASA, MSA, PSA, and then sometimes even MI on that same side, it gets to be a lot of sticks in the mouth. And so that topical will stay put if you just paint it there. But for now, since we're just doing this one injection, I'm going to go ahead and leave the cotton tip applicator in Cammie's mouth. And so this just needs to stay on for 1 to 2 minutes. And so in the meantime, this is where you would typically be assembling your syringe and getting things ready. And so we are going to go ahead and get our needle ready to go here. And we also have our sharps container ready for us and available. And again, those are going to be available really close to each unit, usually between each unit. Okay, and again, you will have your syringes, and most things are found in the top drawer, and your instructors will dispense the appropriate needle and the appropriate anesthetic based on your assessment and what you're telling us the patient needs, and of course we're always double checking that. Okay, so your patient's probably going to need a rinse at this point and some suction, but Cammie is doing okay, right, Cams?
Yep.
Especially if you have a nervous patient, you're going to make sure that you keep the syringe out of their sight. And so as I get this ready, again, I'm just going to loosen this at the hub. And the reason behind that is if it's on there very tight, sometimes we get a rebound effect. So if you pulled really hard on this, sometimes it would come back at you and accidentally cause an OEI. And so again, just loosening at the hub just a hair, not all the way because we don't want it to fall. Remember that this needle tip needs to stay sterile, so it cannot touch the tray cover, it can't even touch sterile gauze. So we're going to make sure we protect it. As soon as that cap comes off, it doesn't touch anything but the patient's tissue. So now that I have this loose, I'm going to grab it palm down, and I sometimes don't even need to touch it. And now I'm palm up, and as you see, I'm holding this with my first finger and my middle finger. And so you get a lot more security with this grasp than trying to grasp it this way, okay? So make sure this is what you're using. And sometimes you can get a fulcrum, not always, but you want to make sure you leave that fulcrum finger available just in case. You also don't want to have a palm down approach. You lose control with palm down. And so either palm to the side or palm up is preferred. Palm up gives you the most control. So as you can see, there are some drops sort of coming out the tip. And so this is where you can practice aspiration. So if you have a drop on the tip, you should be able to very gently pull back and suck that drop back in. So if you were in a vessel and there were blood there, it would be drawn into the needle and go into this cartridge of clear solution, and you would be able to see that you were in a vessel. And we would readjust and make sure that we don't deposit right into that vascular system. So you can practice aspiration without touching anything. So have that droplet and just a tiny bit of pressure. You getting my thumb there? Pulling back. It doesn't take much. If you pull back too hard, you're going to get some really big bubbles here. And so if you have some really big bubbles and you injected those, you could cause an embolism. And so you want to make sure that you don't have a lot of bubbles. There's going to be tiny ones, but there shouldn't be big ones. And if there are, you want to make sure you do not inject that. Okay, so we are communicating with our patient appropriately, okay, and we're just keeping this out of her sight. So I'm going to make sure I retract the tissue. Okay, so if you don't retract very well, it's really hard to tell your depth of penetration. And so if you need a 2x2, we can go ahead and use that. Okay, so now the depth of penetration for an MSA is just a quarter length of the short needle. And so, Cami, you're gonna feel just a little pinch here. And I'm following the long axis of the tooth. And I'm going to insert just a quarter length of that short needle, which isn't very far at all. So now I'm at my target area. It is then that I aspirate. So now I'm pulling back on that harpoon, and if I were in a vessel, we would see blood in that cartridge. We do not, so we have a negative aspiration. So I'm going to very, very slowly, if you can pan in on that stopper, moving. So it should take me almost a minute to get to the halfway mark of this cartridge. So you can see that I'm going really, really slowly. So ideally, it takes 2 minutes for a full cartridge. So there's no need to rush, and so we are reducing our risks for our patient by going very, very slowly. And after we have administered an appropriate amount, especially if we're doing a PSA or an IA, the first thing we're going to want to do is give our patient some suction and a rinse. However, the first thing that we should do, and we are going to do, I'll go ahead and withdraw. Sometimes there's a little bleeding with withdrawal. She did not, but we're going to very carefully, the very first thing we do is recap that needle. And so to recap, we're going to make sure we're not touching anything in this area that could cause an OEI. This is the most dangerous time for an OEI now that it's penetrated the tissue. So now that it's inside, now I can secure it with my fingers, or you can simply engage the lid by pressing down. Okay? So now we have made that needle safe. So once that needle is safe, we can go ahead and give our patient a rinse and some suction. If we know that we have completed all of our injections, we can go ahead and take this needle off. It's the safest thing to do. So to do that, you want to just start to twist, and you're kind of pressing as you're twisting lefty-loosey, because if you don't, it will come off before it's disengaged. That cap will come off. And so we'll twist until it's all the way loose, and remember that this syringe penetrating end is also a danger for OEI. So make sure we're not touching either end at this point. So now we're going to just hover over the sharps container and pop this needle in without even touching it. And then our gloves are still clean, and we should be able to start our treatment. We're also going to dispose of the cartridge in the sharps container. So as we pull back, you'll see that harpoon disengaging. Okay, and now we can pop that cartridge out, and it can safely go into the sharps container. Okay. And so it's important that we stay with our patient at this point, because we know that adverse drug reactions typically happen within the first 5 minutes. And so here is where we can enter our charting in EagleSoft. We can record our notes, and it's very foolproof. It asks you what type of local anesthetic you've given, which injection, which side, did you use topical, what type, which local anesthetic solution, the concentration, including whether or not it has epinephrine in it, how much you deposited, and we will record in cartridges rather than milligrams, whether or not there were any adverse drug reactions, and your name. And so, easy enough.